activities, and I really appreciate her help, and it is a great encouragement to us. Today, Dr. Gayani is presenting some biochemistry case scenarios to us. Dear Gayani, thank you for allocating your time for us in spite of your busy schedule. We are grateful for your presence here today, and I'm sure that this will be a valuable experience for all the attendees present in this meeting today. Over to you, Guy.
Thank you, Kisali. I hope you all can hear me.
Yes, we can hear you.
Okay. Thank you so much for inviting me for this webinar series. I really appreciate you all. And I do hope that I would give some education aspects of some biochemistry case scenarios, which I have seen through my day-to-day activities as well as the clinic experience. So I would like to share those with you. And I would appreciate if you all can participate, which I have done a small kind of few questions with each case, which make this as an interactive case discussion. So for that, can I share my screen now?
You can share.
Yeah, okay. Can you see my first slide?
Yes, Gayani, we can see.
Okay. And I just wanted to see whether it's moving. Can you see the second slide?
It's moving.
Yeah, okay. All right. So I would like to all of you to go to Google search and not this time, but maybe my third slide onwards. So I have menti.com, which is kind of an app that you can use to vote your answers for my questions. And there is a code for you to use that. So if you Google that as Mentimeter on your device, either a phone or your computer, that it will ask you the code, which will be 34824079. So I'll put that number again when I move my slides on and go into the question. So you have to just vote your answers, that which I can see in my screen, and then we can discuss. Okay, so moving on to my first case. This is a 46-year-old male who were presented as with clinical details on their request form. It says erectile dysfunction and tiredness. And this request came from primary care, which they have requested testosterone, thyroid function test, urea and electrolytes and creatinine, and the full blood count. This patient has had a previous vitamin D deficiency, but there's no previous abnormal TFTs or sex hormone abnormalities. So the initial results I got, which are on my screen, was testosterone, which was 6.8. If you appreciate that it is quite low than the reference range, which is 8.3 to 30.2, that is what we quote here in my lab. And then the TSH, it's quite interestingly, the TSH is quite higher than the reference range, which we quote, the upper range is 4.94. And then the free T4 is low, which very well below than the lower cutoff. And full blood count and use and ease were quite normal. I hope you could get the significant features here, and I would like you to answer my question. So if you could go to Mentimeter on Google on your app and put the code 34824079. Are you with me? Did you manage to go to the Mentimeter?
We'll wait some time, Gayani.
Yeah.
Gayani, do we need to create a login there?
No. there's no login, just Google Mentimeter. I hope this technology works, but we'll see. Anybody managed to go to Mentimeter?
Gaya, can you manage?
No, I think we need to log in and like have to.
Yeah, something like
No.
that, Gayani. I think
From Sri Lanka, we have to do that.
Really?
Yes.
Oh, okay.
we just discussed, no?
It is something just accessed by anybody without account.
Madam, we can see that there are multiple choice questions.
That's fine.
Yes.
So did you manage to put the code as well, Luina?
Yes, madam. Yes, madam.
Okay, then you can answer the question. So there are 5 options, and maybe all 5 will be right, or maybe one of them right. So my first option is add either LH and FSH retrospectively to the same sample. And my second option is add cortisol, and the third is vitamin D addition, and then prolactin. And the final answer is inform clinician and discuss the case. You could vote now. I can go back to the answers if you would like. Is it working for others? Yeah, it seems working. I don't know how many participants we have. So at least if I expect about 50% of you could answer, then we can discuss.
Hi, today we're looking at how to
Okay, I'll move on. So a few of you have been able to answer the questions. So so if I go back to my first screen, so you would appreciate that the testosterone was quite low. So quite a few of you have answered that we would like to add a LH and FSH. Which is quite great. And the last answer that you would also inform and discuss this case with the requesting clinician. And the fourth option is again right, so add prolactin. So it's basically almost every answer here is right, but I would appreciate that you all have come with the right answer with the LH and FSH, because we want to find out why the testosterone is quite low here. Right, so this is what I did. So I added LH and FSH. Luckily, this sample was taken in the morning, and the cortisol also was added. And these are the results. If you could see that the cortisol was quite low, which was 71. And the thyroid hormone, as you know, it has a different pattern to the pituitary hormones. So it shows kind of a primary hyperthyroidism in the background, but the rest of the other findings, more LH and FSH quite in the lower range, and testosterone was quite low. So that might be suggestive of a possible hypopituitarism, because the cortisol has low as well. So then it's worthwhile discussing this case with the requesting clinician, which we did. And then the patient was referred to endocrine. So then following that, so the endocrine actually has treated his thyroid hormone abnormality. They have treated the patient with thyroxine, and then the thyroid hormone stimulating hormone has come back a little low, and the free T4 was up, and the prolactin was marginally elevated, but we do run macroprolactins in our lab when the reference range, the prolactin is above their respective reference range. And so this has a slightly high prolactin, but I think it's not quite specific here. But the testosterone, repeatedly, it was quite low. And then the insulin-like growth factor 1, which is lower than the cutoff, and the 9-AM cortisol on repeat, it was quite low. So this case discussed that this patient has dual pathology, and one is primary untreated hypothyroidism, probably Hashimoto's, and then secondarily, this patient also has hypopituitarism, and they have done an MRI head which shows pituitary hemorrhage. That was the cause for that hypopit. And there was no history that's suggestive of any headache or visual problems or past medical history as such. So I just, so then they treated the patient. Anyway, the patient was on thyroxine. And then apart from that, they started them on testosterone and hydrocortisone. And this case was discussed as an urgent neuropituitary imaging MDT with the regional team, which is Oxford. And then patient underwent pituitary surgery. And following the surgery, patient was recovered well. And luckily, that patient could come off hormone replacement, and the monitoring bloods shows normal pituitary profile later on. So I just wanted to give you some take-home message from this case. One is that it is quite a great value if you could add some test onto the existing sample when you see such low hormonal abnormalities, because you could identify untreated hypopituitarism by that way, because sometimes the requester might not request everything in one go, but it is good that if you could build up the rest of the clinical picture for a diagnosis, because most of these patients quite come up with non-specific symptoms. And also pituitary apoplexy, a little word about that. It's a diagnostic and therapeutic challenge, and it requires multidisciplinary approach, and it may require prompt surgical decompression. And they say once the patients undergo these surgeries that they might not need long-term hormonal replacement, but pituitary function should be reassessed over the time, maybe medium or long-term, because there can be a resolution of existing deficiencies or maybe even development of new ones. Those are the case reports that found with this kind of diagnosis. Right, I'm moving on to my second case. Do you have any questions related to the first case, or are we going to discuss anything at the later stage after the whole webinar? It's up to you, I don't mind. Okay, so since so I'll move on to my second case. So this is a young female who is in their second pregnancy with the gestational age of 30 weeks. And again, this one actually a presentation to the hospital with a history of 24-hour epigastric pain. There was a history of hyperlipidemia type 3, but no history of diabetes or gestational diabetes. And then this patient also has had B12 and folate deficiency. Anyway, she was on pre-pregnancy treatment for that. And no family history of diabetes, no cholesterol or triglyceride disorders in the family, and there's no premature heart disease. She was an ex-smoker, but no alcohol history as such. And on admission, the patient was taking the usual pregnancy supplementations, folic acid and B12. and also omega-3, which is one of the supplements or a medication that can be used in hypertriglyceridemia, because this patient is now pregnant, so cannot be used other lipid-lowering medications, but omega-3 it can be used. So prior to the omega-3 in her pregnancy, she has been on a fibrate and a statin because this patient already had a background hyperlipidemia. And her first pregnancy was uneventful. She has delivered one baby with no complications. So it's quite a big history, but you need to take into account that this is a pregnant lady coming to hospital with an epigastric pain. That's all we have as the clinical features. Right, so I'm moving on to my second questions. I would like you to free text your answers about which investigations would you offer for this lady at this stage. If you could go to your Mentimeter, probably you may have to put your code again, which is 34824079, and just type in your answers. So any free text would welcome. I'll go back to the first slide. Are you with me?
Yes, Gayani.
Okay.
Can you move to the questions slide, Gayani?
It's just a free text. So yeah, it's not a multiple choice. So you can just type in. I can't see any responses yet. Don't know whether it's working. Anybody managed to get into the question?
One has entered.
Okay, yeah, good. Okay, shall I reveal your answers? I don't know how many could manage. Very good. Thank you so much. So all of you are going in a direction of finding why this patient presentation is. And I guess that you all are thinking about acute pancreatitis. And you almost everyone need an amylase and lipid profile, and also looking for liver functions. Oh, troponin as well. All right, good thought. Let's see. Right, so I just wanted to show you, just to share her antenatal bloods. So actually this patient didn't have anything at all when she came into the antenatal clinics. The hemoglobin and the full blood count, I think it's just more down to the pregnancy status. And the vitamin B12 and folates were within the normal range. And glucose tolerance test, I think they have performed because there was a family history of diabetes, which the result come back as normal. And if you could appreciate that this sample, when it came from antenatal, it was grossly lipemic, but unfortunately, they have not had any lipid profile on that sample. It was not requested. And these are the admission bloods. So her ALT slightly elevated, not much, but amylase is not increased by just near the upper margin. CRP is slightly elevated, and protein creatinine ratio was okay. And if you appreciate her lipid profile, it's quite increased. So the units that we use here is millimoles per liter. I think you need to convert it with multiplying by 36, or if it is triglycerides, it's 84 something. So I think it's quite high. You should appreciate that the trigs is 86 and the total cholesterol 34 is very, very high readings on these bloods. Right, so the amylase was repeated a little while later, and it went up to 372, and lipase was slightly high as well. CRP increased, LDH is fine, and the calcium was going down. And then the ultrasounds and the MRI findings were suggestive that this patient having an acute pancreatitis. Okay, so the next question, if you all go to your Mentimeter and vote for this question. So there are, it's a multiple choice question, but there might be more than one answers. So just just give your response for this question. Okay. I think lots of you have answers, it seems. So quite a number of the forum is going for the second answer, which is hypertriglyceridemia-induced pancreatitis in pregnancy. And some were thinking of drug-induced or type 3. I would say you can think about it because this patient has a background history of type 3 hyperlipidemia. But the drug-induced is a little bit unlikely here because we don't have any drugs that can cause pancreatitis in this scenario, and the patient does not have any history of alcohol either. And familial combined hyperlipidemia is again a little bit unlikely because this patient does not have any family history as such. So we diagnosed this case as severe hypertriglyceridemia-induced pancreatitis in pregnancy. So then the obstetric team at that point had asked advice from us. So what we gave at the initial stage is just to limit or go for a zero fat diet. And you can't treat the patient with fenofibrate because it's contraindicated in pregnancy. So these patients, the OBS team was, they reach to dietitians and get the zero fat diets, and they manage the acute pancreatitis as it is in a normal scenario with nil by mouth and etc. And then, however, the patient deteriorated the same day and she required ITU care. And because the triglyceridemia was quite severe and it ended up with electrolyte disturbances, and there was metabolic acidosis and hypoxia kick in, and then the patient has to undergo plasmapheresis, which is kind of the treatment option at this stage. So she went 2 cycles of plasmapheresis, and the patient was kept fat-free the entire length of the stay. So if you could appreciate the trigs and cholesterol, how they came down. So at very high levels, if you can see my mouse moving, and then it just went very down to around 5 millimoles, and it just went that way and kept on that range for a while. Similarly, cholesterol came down quite significantly with plasmapheresis. And the other parameters improved as well. The calcium improved because she started with the hypocalcemia and then came to normal range of calcium. And the pH was started with an acidosis, but then slowly improved and came to near normal pH. Right, so a little bit about acute pancreatitis. It's very rare. It's a rare cause of abdominal pain in pregnancy. And the cited incidence, actually, it's about 1 in 1,000 to 10,000. And these patients presents, majority of them presents in the 3rd trimester or very late stage of their pregnancy, and some may present in early postpartum. The complications are tremendous, and the fetal death is quite high, whereas the maternal death as well. And these pregnancy-associated pancreatitis may occur in the background of gallstones disease and excess alcohol, or even previous history of hypertriglyceridemias. And hypertriglyceridemia-induced pancreatitis in pregnancy accounts for about 4% of all cases of acute pancreatitis. So it's kind of a little bit rarer situation. And what happens in pregnancy? What happens to your lipids? So during pregnancy, you have your hormonal changes. The estrogen, progesterone, and human placental lactogen comes into play, and the plasma lipid levels increase. Usually in the 1st trimester, they are quite similar as the pre-pregnancy levels, but the significant changes can happen at the later stages, in the 2nd and 3rd trimesters, and usually the plasma triglyceride can increase 2 to 4-fold during pregnancy, even if you don't have any pre-pregnancy lipid disorders. And sometimes level can go up to very high levels, about 11.4 millimoles. In other words, it's 1,000 milligrams per deciliter. And because the estrogens are elevated, then it leads to downregulation of the LPL gene expression, which decrease your LPL activity, and then it decreases the clearance of VLDL cholesterols, and also it increases the synthesis of triglycerides and VLDL in the liver. So there are quite a number of mechanisms how these lipids go up in pregnancy. Right, so just to recap your revision, so I'm just wondering whether you could answer this question. So I'm just asking you the causes of hypertriglyceridemia. This is irrespective of the pregnancy. What else do you think why your triglyceride can go up in the bloods? Again, it's a free text answer. I just want to keep you engaged in the discussion. That's why I have put some of the questions into this case. If you could type in your answers, that would be great. Please go to Mentimeter and use the same code. Okay, thank you. You've come across almost every answers that you can think of. Very good. I just share what my list would look like. Oh, good. So renal, obesity, diabetes, and all sorts of familial types you have come across, and you have answers are there. So I would just classify them as primary and secondary first, in case that it is quite easy for you to remember them. So the primary hypertriglyceridemias that we know, it's familial chylomicron syndromes, which is associated with the deficiency of lipoprotein lipase or ApoC2. And then all your secondary causes come onto one side that you can name as you want: diabetes, medications, pregnancy, alcohol, obesity, or any metabolic syndrome, and even renal disorders. Okay, so just to recap or refresh your knowledge. Right, so in this case, we don't know actually the exact mechanism of hypertriglyceridemia-induced pancreatitis. They say it because the triglyceride might accumulate around the pancreas, which are hydrolyzed by pancreatic lipase, and these free fatty acids then accumulate, they are very toxic, and they will damage the capillary endothelium. And at the same time, these increased chylomicrons can lead to capillary plugging, ischemia, or acidosis. So in this acidic environment, these free fatty acids activate trypsinogen, and then they trigger acute pancreatitis. And how do you manage these patients when they have this severe disease in their pregnancy? As I mentioned earlier, lipid-lowering agents in pregnancy are quite limited. It's only safe to use omega-3 fatty acids, but there are case reports in the publications that they say they have treated with nicotinic acids, but there's not much, they don't advocate that as much. And fibrates, quite limited because very little data is available from well-designed studies. And statins, as you all know, it's potentially a teratogenic medication, and then you cannot be used that in pregnancy. And what happens with the insulin and heparin? So again, some people, they tend to use insulin and heparin because insulin enhances lipoprotein LPL activity, and it will lead to chylomicron degradation. And similarly, heparin stimulates the release of LPL, which also adheres to endothelial cells. So the combined effect is to get rid of the serum triglycerides. So apheresis is the treatment of choice with very severe cases. It can drastically reduce your triglycerides. As well, it will reduce the inflammatory cytokines, and then it replaces deficient lipoprotein lipase or apolipoproteins because the plasma is used as the replacement fluid. And there are a number of guidelines, and American Society of Apheresis guideline, they have mentioned apheresis as a well-established therapy. And there are also studies that they have compared the effect of plasmapheresis versus the conservative management. But interestingly, the morbidity and mortality in cases of this HDG-induced pancreatitis found no statistical difference. All right. So this patient actually delivered that baby by normal vaginal delivery near to term. And then she was kept on omega-3 for a while in her postpartum with the low-fat diet. And immediately post-delivery bloods actually came back to normal with slightly raised cholesterol, but very normal triglycerides. And then there was a question about her diagnosis, whether the previous type 3, which was made in her previous clinic, whether it's accurate. So repeated the ApoE genotyping, but it came as negative, so it was not supporting the initial type 3 diagnosis. So we thought whether this might be a polygenic hyperlipidemia, which was precipitated by pregnancy. But anyway, the familial chylomicronemia syndrome genetic panel was sent. However, with some later on, after some months after her delivery, her cholesterol and triglyceride was again rising. This is without any medical management, but only with the careful diet. So then she has to undergo, she has to start it again on atorvastatin after completing the breastfeeding days. Okay, moving on to my third case. So this is kind of an analytical question, I would say. So it's a young male, came to an NHS health check, and he has a history of primary hypothyroidism and was on thyroxine for a long time. And there is a family history of type 2 diabetes, and they have done an HbA1c test just to rule out as diabetes as a screening test. Clinically, he did not have any features of diabetes. These are the blood tests on our system up to date. That was from 2015 until 2018. So his plasma glucose is almost every time when they did, it was quite normal. TSH going up and down, I think with the compliance and the inadequate treatment, probably because the patient might be not taking the thyroxine. Renal function is quite normal. Total bilirubin is slightly higher than the upper margin, but the patient was asymptomatic. Hemoglobin was quite normal. Liver functions fine, but if you could appreciate their HbA1c, it was very raised despite normal plasma glucose. So we have in our lab is the BioRad D100, which is an ion exchange HPLC method for HbA1c. So these results are from that analyzer. Okay, so what do you do next? What are your thoughts on this case? So this is a very normal patient with no history of diabetes or family history, only hypothyroidism. Just came for a screening to rule out diabetes, but the HbA1c is quite high despite normal plasma glucose. If you could answer my next question, what would you do? So again, it's multiple choice. Maybe one or more answers probably are right here. Okay, good. So almost all of you want to repeat this HbA1c on a different platform, and also you would like to exclude an hemoglobinopathy. Yeah, good. I don't think anybody will offer treatment at this stage, and doing fructosamine is not useful here because there is no previous diagnosis of diabetes, and fructosamine, you all know that it is used as a monitoring test if you can't use HbA1c. Glucose tolerance tests might be useful, but we have to go for that after you finish the other two. Okay, right, so going backwards, this patient's history going up to 2016, it has a diagnosis of some variant in hemoglobin, which called carrier of HB negata. And the HbA1c test on the last sample was repeated on a different platform, which is boronate affinity method. And the result came as 30, which is quite normal. So we think that this discrepant HbA1c on the first instance on the ion exchange chromatography probably, possibly, it's an error reading because of the presence of unusual hemoglobin variant. I think the high bilirubin, I couldn't find the association as such, but it might be an undiagnosed Gilbert syndrome, or maybe an intravascular hemolysis, or maybe something related to this hemoglobinopathy. Right, so a little bit about ion exchange chromatography, HPLC and A1C. So actually hemoglobin F concentrations up to 30%, it won't interfere with the test. And beta thalassemia traced as indicated by increased HbA2, again, will not interfere. And physiologically occurring concentrations of LA/LA1C or carbamylated hemoglobin or acetylated hemoglobin, again, would not interfere. And most of the therapeutic drugs at the therapeutic concentrations do not interfere. Bilirubin, glucose, rheumatoid factor, or total protein, there's no significant interference. And heterozygous form of hemoglobin variants, which you all know, HbA, C, D, or E, they do not interfere, but the homozygous or double heterozygous forms will definitely interfere. So we can't use HbA1c if this patient, if the patient has these in their background. Right, so just to show you a normal chromatogram. So this is the HbA1c peak, and this is quite normal other peaks for A1, 1A, 1B, F, etc. And these two are abnormal chromatograms. This is HbC, and this is HbS. And if you could see that the broad peaks are there which interfere this HbA1c component. So it won't give you accurate A1c concentration or the area percentage. Right, so I'm not too sure whether you still have A1c in your labs, but if you have, based on your methods, if you come across an abnormal chromatogram in your lab, what would you do? It depends on your experience, but I would like to see your process of handling these abnormal chromatograms. Again, this is a free text question, so you could type in whatever you would like. Go to Mentimeter and put your code and type in the type your answers if you have any. Yeah, very good. Thank you so much for your answers. So most of the labs in the clinical use, they use ion exchange chromatography for HbA1c, and some they do affinity methods. So what we do in our lab, actually, when we find a variant, we just go back to their history. If the history does not suggest you of any sort of hemoglobinopathy, we would report this as a possible abnormal hemoglobin band. Your result is unreliable, suggesting to hemoglobinopathy screening if they required. And if the patient is having diabetes already, please use fructosamine to monitor. And if the patient, by any chance, if the history is suggestive of any variant, then we would report this as normal hemoglobinopathy with possible interference. And again, monitor diabetes with fructosamine. But for diagnosis, as I mentioned earlier, you should always suggest them to do a glucose tolerance test. Right, so my fourth question, I think I've got 15 minutes, but I got 2 questions. We'll see how we progress. If the time is short, then I will finish with this case. Okay, so I hope you all are still with me. Sorry for the long questions and scenarios and the exercise. Right, so this 4th question, this is a lady who is 71-year-old, known hypothyroidism. There's no family history of thyroid disease, well controlled on levothyroxine 75 once daily. Unfortunately, she has had a lung carcinoma, which was detected in 2017, and she was started on chemotherapy, which is 6-platin plus pemetrexed, but the response was not great, so they stopped the chemotherapy and investigate this patient for any meds, but luckily there wasn't anything. So then they started on a medication called pembrolizumab in 2018. And this medication is a monoclonal antibody, which is a medication that you can be used in cancers. And the patient was tolerating this well without any side effects. So these are the blood test readings from 2017 up to late 2020. And so bear in mind that she has a background history of hypothyroidism and was on treatment for that. So her baseline thyroid, the TSH and the free T4 was quite normal, which is biochemically euthyroid. I'm sorry about the reference range. So free T4, our upper limit is 19. So she was very well behaving euthyroid at this stage. But then in 2018, she was started on this MAB treatment for her cancer. And if you could appreciate that the TSH, while she was on thyroxine as well, it was suppressed, very suppressed with a high T4 and a high T3. And the reference range or the upper limit of free T3 is 5.7. So it's almost a thyrotoxic picture here. And then later on, after a month, her TSH, again low, but not very suppressed as before. And her free T4 is a little bit normal, I would say. And it was there until late 2018. Bear in mind, this patient was on thyroxine. They didn't stop thyroxine. So the patient is on thyroxine while continuing the chemo. And later on, October 2018, if you appreciate that her TSH is going above the reference range and the free T4 is coming down despite her being on the thyroxine. And 2019, what happened? She's profoundly hypothyroid, and they had to increase the thyroxine to 150 micrograms. She's still on chemo, okay? And then early 2020, her TSH came back to euthyroid, and they stopped chemo and they reduced the thyroxine dose. So her chemo was stopped, I think, because she was improving with that and the cycles were finished, that's why. And then late 2020, the TSH was quite normal within the euthyroid range, and she is continuing her thyroxine as normal. Right, what do you think has happened in this case? So this is her basic history. So apart from her normal hypothyroidism, the only change that they did was the new chemotherapy, which is a monoclonal antibody, started in 2018. Please go to Mentimeter and free text your answers, please. Any guesses? Oh, come on. I just wanted to keep you awake, and I know the time in Sri Lanka is almost kind of after lunch. Probably it's not the right time for you all, but anyway. Oh, thank you so much. So 2 of you have come up with answers. So yes, it's the monoclonal therapy, and it's clearly said as a first answer, it's the thyroiditis. Right, so what is monoclonal antibodies? So there are quite a number of uses of monoclonal antibody therapy. And one is treating cancers. And then also there is angiogenesis inhibition. And also we use them as checkpoint inhibitors. So these are the common medications that's available, and it's widely used in this part of the world, but I think it's still there in the other parts as well. But if you, the top 4 are called checkpoint inhibitors, and they're mainly used by oncologists, and they all have MAP at the end, which is monoclonal antibody. And it's very difficult to pronounce, but I would say these 4 are commonly used by oncologists for melanomas, Hodgkin's, lung cancers, etc. And the bottom 3, they are not checkpoint inhibitors, but they also used in multiple sclerosis. And our patients who was having pembrolizumab, which is PD-1 immune target checkpoint inhibitor. So how they work? So in this diagram, you could see this is a T cell, and it has receptors attached to their epithelium. And CTLA4 and PD-1, these are 2 receptors that's targeted by these immune inhibitors. So normally, if there is a cancer cell, they also demonstrate the ligands for this, and they can bind to these receptors. And when they bind, actually, they just go invisible, and then they go and proliferate somewhere else and growing the cancer cells more and more. But if you have these inhibitors, the checkpoint inhibitors, which is CTLA4, which are, for an example, ipilimumab, and then PD-1 inhibitors, which is nivolumab or pembrolizumab, when they are there, they inhibit these receptors. So then the cancer cells, they cannot come and attach to your T cell. Then what happens is that the cancer cells again are visible. So they go into apoptosis, and then the cancer cells get destroyed. So that's the mechanism of these monoclonal antibodies, and especially the checkpoint inhibitors, how they work in our body to treat these cancer cells. So unfortunately, with these medications, there are quite a number of endocrine immune-related adverse effects happens. Thyroid gland is one of them, and then hypophysitis you get, and your adrenals can be affected, and also diabetes can come in. So these endocrinopathies come up with non-specific symptoms. So it's very important that you distinguish between primary and secondary dysfunction is there, because it might be either hypophysitis leading to hypothyroidism, or maybe it's primarily the gland is affected. And so it's very important to do your TSH as well as your free hormones to identify that. And they say hypophysitis is induced by mainly anti-CTLA4 maps, and primary hypothyroidism with high TSH and normal or low free T4 is seen more with anti-PD-1 or PD-L1 maps. So the incidence of this thyroid dysfunction with these immune checkpoint inhibitors reported as hypothyroidism around 6.6% and hyperthyroidism around 3%. This is from a meta-analysis from 38 studies. It was reported in one of the oncology papers. Why it occurs? So it might be a destructive or inflammatory, or frequently it might be a transient thyroiditis resulting in release of thyroid hormones, which will go to thyrotoxicosis and then followed by either clinical or subclinical hypothyroidism. Even it can develop to thyroid eye disease, and occasionally very severe forms of thyroid disease such as thyroid storm. The mechanism is quite not clear. They say it might be T cell or natural killer cell mediated cytotoxicity, or maybe there are expression of these receptors on the thyroid gland as well. So there are guidelines available when somebody is on these checkpoint inhibitors, how frequently and which thyroid test or other antibodies that you need to check. So for thyrotoxicosis, it is usually mild. So beta blockers is enough actually. Antithyroid drugs are very rarely needed. For hypothyroidism, the treatment is thyroxine, and it also depends on their TSH and their symptoms. If they are asymptomatic and the TSH is less than 10, they usually just observe them. But if there is full or partial, if there is high TSH with symptoms, they probably start on thyroxine. And as usual, the dose adjustments can happen in 4 to 6 weeks time with an assessment. So other than the checkpoint inhibitors, I talk about the non-checkpoint inhibitors. They also, if these are the drugs that for some other cancers that the patient is on treatment, they can result in autoantibody production, which leading to autoimmune mediated defects. And autoimmune thyroid disease is also common as a side effect. And this can be a mild to moderate severity, and then the patient has to be on screening for about up to 5 years since last infusion. So the effects are quite long lasting. So as I said before, there are guidelines available for the oncology teams to look when they are treating these patients on these medications. Okay, I think my time is up, Kisali. Do you want me to go for this last case, or I can stop if you want?
I think, Gayani, it's better to stop and go for the questions.
Yeah.
The participants, if you all have questions, I think there is time. You can talk to Dr. Gayani. She is with us. You can discuss cases with her if you want further.
Hello.
Yes. Hi.
Hi, Gayani. Can you hear me?
Yes, yes, I can.
Let me first of all congratulate you for a lovely, a very interesting presentation. And it's a great pleasure to see you, our own trainee, presenting very interesting presentations from UK. I have one question for you, Gayani.
Yes.
This is when we're doing the lipid case, what came into my mind is whether you have facilities to do lipoprotein lipase in UK.
Yes, we have facilities for that. Yeah,
and
I haven't.
C2 levels as well.
Sorry, say that again.
C2. Lipoprotein lipase for primary hyperlipidemia type 1, you do the lipoprotein lipase or the C2 level. So probably you have.
Yeah, we have facilities to check the levels if we want.
Where can we access this?
The Cardiff is one of the main lipid centers.
Okay.
Where we could send samples, and there are other genetic labs now available in the UK because initially there was no funds, but now it's with the NHS England funds. There are other hot labs. They do also have genetic testing available. So
that is genetic testing.
And the C2, and the other markers as well.
Well, okay, right. Thank you.
Okay, if you can't unmute, please raise your hand. We can unmute you. Gayani, what about the antibody interference, the thyroiditis case? Can it be antibody interference usually not with that drug? The monoclonal, you said, sorry, the antibody, can't it be antibody interference?
Not really. Actually, it was not tested, but this patient initially, before starting on the monoclonal antibody therapy, her thyroid functions is quite matching with her presentations and her history. So she already has had a diagnosis of hypothyroidism, and she has been on thyroxine. So there was no discordant TFTs along with the previous presentation or the medications that she had before she started on the monoclonal therapy. So it is unlikely that there is an interference analytically just with thyroid antibodies. I think you are trying to think about the heterophil antibodies, etc. Is that right, Kisali? Is that what you were thinking of?
Sampath is with us, he can talk.
I thought that drug is, as it's a monoclonal antibody, that antibody go and interfere with the analytical our antibodies using the analyzer.
Yeah, if it was an interference, then I don't think that you would see the pattern going both ways, isn't it? So at some point the patient was thyrotoxic, and the next point the patient was hypothyroid. So if you would expect an interference, either it will affect either TSH alone, or maybe just it's most of the times it might be TSH, but it can also affect, I mean, the interference can affect on free hormones assay as well. But I do believe, I don't know whether I'm right, but I think if there was an interference analytically, then your pattern of TFTs won't change that fast.
Okay, got it. Okay. I think it's time to any more.
Gayani, I'm Samanheva here.
Hi.
Nice to see you.
Nice to hear you, and yeah,
thank you very much for your lovely case presentations and sharing your knowledge. Just to ask you a very small question, quick question. Now, Gayani, we in Sri Lanka use this capillary electrophoresis for HbA1c very often in most of our centers as an alternative method for this problematic HbA1c assays.
Yeah.
Now, for my experience, this borate affinity what you have used is also having a lot of interferences from this co-eluted variants, hemoglobin variants. So how about this capillary electrophoresis? You haven't mentioned anything about that. I was wondering.
No, actually, I didn't go through that extent. Actually, we don't use capillary electrophoresis here in the UK for HbA1c.
What's the reason?
I actually don't know, to be honest. But I think it's the availability with the other methods. So the HbA1c is usually on ion exchange chromatography, and boronate affinity is used as a point of care most of the time. That's just a benchtop small analyzer. Yeah. And most of these spaces, they use it as a second analyzer when you come across a variant, just to check whether it's actually a variant. But it's not accurate, as you said. We can't say it's always, it doesn't interfere. It will interfere, but it's just to kind of get a second answer for your first variant that you would see on your HPLC. I actually don't have experience on capillary electrophoresis, as you mentioned, but the reason behind that was not using is not sure, actually. Sorry.
Right. Okay. So even for your protein electrophoresis, you don't use these capillary methods?
That's for proteins, yes, not for hemoglobins.
All right. Okay.
Yeah.
Even by hematologists for their hemoglobin variant assays. Hemoglobin
probably, I'm not too sure, Dr. Saman.
No, it's okay.
Yeah, capillary electrophoresis is used in normal protein electrophoresis, but in some labs they do not. Is it not come under biochemistry? That's under immunology. But as you said, hematologists probably they just wanted to screen their hemoglobin variants. They're probably using it, but it's again not under our radar. So it's just again with the hematologists.
Okay. Okay. Thank you, Gayani.
I think it's time to end the meeting. I invite Dr. Tushara Hewanegana, Joint Secretary CCPSL, Consultant Chemical Pathologist, Teaching Hospital, Anuradhapura, to deliver the vote of thanks.
Thank you, Kisali. Let me take this opportunity to thank Dr. Gayani Weerasinghe, Consultant Chemical Pathologist, Department of Clinical Biochemistry, Buckinghamshire, NHS Trust, London, UK, and Honorary Consultant Chemical Pathologist, Oxford University Hospital, NHS Trust. Thank you very much, Gayani, for delivering this lecture at the request of College of Chemical Pathologists, Sri Lanka. I also thank Dr. Sampath Kularatna, Senior Registrar in Chemical Pathology attached to MRI Colombo, for coordinating this event. And finally, I thank all the participants who joined us for this occasion from all over the country. Without you all, this event won't be a success. And see you all in another webinar like this very soon. Thank you very much.